Good morning, everyone. Today we are going to talk about the physiology of arrhythmias, and I will divide the topic into two parts, part 1 and part 2. In this session I will talk about, or I will cover part 1. Let's go through the objectives of this lecture. First objective is to define what is meant by the term arrhythmia, then describe how abnormalities of cardiac pacemakers can cause arrhythmias, and then describe conduction defects and the types of arrhythmias that can be caused by these conduction defects. Then we'll define what is an ectopic pacemaker and the factors causing it. Objective number 5, explain the causes of common atrial and ventricular arrhythmias. And then we will classify the arrhythmias and explain the principles of emergency and long-term treatments of arrhythmias. In today's session, the classification of arrhythmia, we will cover the sinus arrhythmia and the atrial arrhythmias, and then I will cover the junctional arrhythmias, ventricular arrhythmias, and the AV blocks, as well as the treatment in part 2. As we know very well, the conduction system of the heart is composed of specified or special cardiomyocytes called the autorhythmic cells. The autorhythmic cells are arranged into the conduction system of the heart, and the conduction system of the heart is composed of different parts. The first part is the sinoatrial node, which is the natural pacemaker of the heart. It is the part of the conduction system that takes control of the entire heart in terms of determining the heart rate or the rhythm. Then another group of autorhythmic cells are collected in a node called the atrioventricular node. Then we have the atrioventricular bundle or bundle of His that will branch or divide into left and right bundle branches, and then each bundle branch will give me smaller branches called the Purkinje fibers. In some textbooks you will find that the SA node and the AV node are connected by 3 internodal pathways, and there is also a bundle that will connect the right atrium to the left atrium. But what we have studied in the introduction, we know very well that the electrical activity or the action potential that is generated in the SA node will propagate through the atrial cardiomyocytes to the AV node. Heart malfunctions or cardiac disorders can be caused by either abnormality of the heart muscle or abnormality of the heart rhythm, what we call arrhythmias. And arrhythmias or cardiac arrhythmias is defined as an abnormality of the cardiac rhythm, which is a change from the normal sequence of electrical impulses or a deviation from the sinus rhythm. Arrhythmias may cause sudden death, heart failure, chest pain, syncope, dizziness, palpitation, or no symptoms at all. So arrhythmias could be asymptomatic or could be severe enough to cause death, because they will, in some cases, they will compromise the cardiac output to a very low level, and this will lead to death of the patient. There are 2 main types of arrhythmias, and these are bradyarrhythmias or bradycardias, where the heart rate is too slow, i.e. which means less than 60 beats per minute during the day or less than 50 beats per minute at night or during sleep. And the other, which is the most serious type of arrhythmia or arrhythmias, are the tachyarrhythmias or the tachycardias, where the heart rate is fast, more than 100 beats per minute. They are more symptomatic, as I said, when the arrhythmias are fast and sustained, so they are present or they affect the patient for longer time, and they are divided into 2 types: the supraventricular tachyarrhythmias or supraventricular tachycardias, and these arise above the ventricles, which means from the atria or the AV junction, And we have the ventricular arrhythmias or ventricular tachycardias that arise from the ventricle or within the ventricles. Arrhythmias can occur in an apparently normal heart, or they can arise or originate in a heart that is affected by diseases, for example, heart damaged by ischemia or infarction, or even the scars that happen after the infarction. Cardiac arrhythmias are usually caused by one or a combination of the following abnormalities of the rhythmicity conduction system of the heart. For example, abnormal rhythmicity of the pacemaker, the natural pacemaker of the heart, which is the SA node. So either the SA node is firing at fast rate or at low rate, or it is firing irregularly. There is another cause or another example of abnormality that can lead to arrhythmia is a shift of the pacemaker from the sinus node or the SA node, which is the natural pacemaker of the heart, to another place in the conduction system of the heart. For example, the AV node will become the pacemaker, or the bundle branches or the Purkinje fibers. Another cause of arrhythmia is spontaneous generation of ectopic impulses in almost any part of the heart. So any part in the wall of the heart that can or that generates ectopic action potentials can become a source of arrhythmia. Another cause of arrhythmia are blocks at different points in the spread or in the pathway that allow the spread of impulses through the heart. For example, or a common example is the AV block. We have different types of AV block that we will discuss them in part 2 of this topic. Then another cause or last one is abnormal conduction pathway. So impulses are transmitted through abnormal pathways through the heart, like in the Wolff-Parkinson-White syndrome that we'll study inshallah in part 2. As I said at the beginning of this session, that the conduction system of the heart is composed of autorhythmic cells, that they have a special arrangement: the SA node, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers, and we have different firing rates for these different components of the conduction system. For example, the SA node fires action potentials at a rate of 60 to 100 action potentials per minute. The atrioventricular junction has a firing rate of 40 to 60 action potentials per minute, while the Purkinje fibers, they fire at a rate of 20 to 40 action potentials per minute. So the pacemaker cells in the lower areas, such as the junctional tissue and the Purkinje fibers, normally remain dormant because they receive impulses from the SA node, because the SA node has the highest firing rate, and this will cause overdrive suppression to lower or more distal components of the conduction system of the heart. The SA node, the AV node, and the Purkinje fibers, they can initiate an impulse only when they do not receive one from above or one from the SA node, such as when the SA node is damaged from the myocardial infarction. So if the SA node stops firing, then the next component or part of the conduction system that has high firing rate will be the AV node or the AV junction. So the AV junction will become the pacemaker of the heart. If the AV junction fails to fire for any reason, then next in terms of the firing rate are the Purkinje fibers. They will take the lead and they will become the pacemaker of the heart in that situation. Both bradycardias and tachycardias, or bradyarrhythmias and tachyarrhythmias, could be caused by either abnormalities of automaticity, which could arise from a single cell, or abnormalities of conduction. So there is abnormality in the impulse conduction down the conduction system, and this requires abnormal interaction between the cells. So bradycardias and tachycardias can arise from abnormalities in automaticity or conduction or both together. And we can summarize here the causes of arrhythmias, either, as I said, disorders of impulse formation or impulse generation, and this is a problem in automaticity. For example, altered normal automaticity. The SA node is firing too fast or too slow, or abnormal automaticity. Some other parts of the conduction system are becoming the pacemaker of the heart. Also, disorders of impulse formation, something called the triggered activity, and I will explain that later on in one of the coming slides. It could be either due to early after depolarization or delayed after depolarizations. The other cause of arrhythmias is disorders of impulse conduction. This could be a block along the conduction system of the heart, and the most common example is the AV blocks, the different types of AV block. Another cause of arrhythmia that arises due to disorder of impulse conduction is the reentry, or we call them circus movements, and I will explain them later on in one of the coming slides. For example, the bradyarrhythmia could be caused by disorders of impulse formation, like too slow firing rate of the normal pacemaker of the heart, which is the SA node, or different types of block. So bradyarrhythmia can arise either due to disorders of impulse formation or disorders of impulse conduction. Tachyarrhythmias or tachycardias could be caused by disorders of impulse formation in the form of abnormal automaticity, like altered normal automaticity or abnormal automaticity, so the pacemaker is outside the SA node, or due to triggered activity or reentry circuit. So we have different mechanisms and different causes of the tachyarrhythmias and bradyarrhythmias that affect the heart. As I said, the sinus bradycardia is usually a result of abnormally slow automaticity, which means that the SA node fires at a low rate, below 60 or below 50 at night during sleep, while bradycardia due to AV block is caused by abnormal conduction within the AV node. So either abnormal automaticity or abnormal conduction. These two can explain the bradycardias. On the other hand, the mechanisms that generate tachycardias are accelerated or enhanced automaticity caused by hypoxia, acidosis, hypocalcemia, digitalis, toxicity, etc. And this is where the SA node fires at a higher rate, at abnormally high rate. And we have another cause or another mechanism, which is the triggered activity that arises in injured atrial or ventricular cells. And finally, we have the reentry, or we call the circus movements. Let's talk about triggered activities as a possible underlying cause of tachyarrhythmias or tachycardias that affect the heart. Triggered activities are secondary depolarizations that accompany normal or premature action potentials. And we have two types of triggered activity. We have the early after hyperpolarization, and these are oscillatory potentials that occur during the action potential plateau. And we know very well that action potential has several phases. We have phase 0, phase 1, 2, and 3, and then phase 4 back to the resting membrane potential. So early after depolarizations are oscillatory potentials. They affect either phase 2, which is the plateau, or phase 3, which is the repolarization phase of action potential. If the amplitude of the oscillations is sufficiently large, neighboring tissue is activated and a series of impulses are propagated. We can see here that an oscillatory movement is affecting the action potential during phase 3, during repolarization. And if it is strong enough, it will cause or activate the nearby cells, and this will lead to or it will trigger activities in neighboring cells, and that's why we call it triggered activity. The other type of after depolarizations is the delayed after depolarization. It happens after attaining the resting membrane potential, where a secondary deflection occurs which might reach threshold potential and initiate a single premature action potential, as we see here. After recovery and the membrane potential goes back to phase 4, or the resting state, resting membrane potential, and oscillatory activity will happen. If it is strong enough to reach threshold, then another action potential will be generated. So after depolarizations occur only in the presence of a previous action potential. So we need a previous action potential to get the triggered activity. So we need a trigger, and the trigger is the previous action potential in both early after depolarizations as well as in delayed after depolarizations. Now let's talk about reentry or circus movements. They occur primarily due to abnormality of conduction. So this is under the abnormality of conduction as a cause or as a possible mechanism for arrhythmias or tachyarrhythmias. An impulse may recirculate in the heart and cause repetitive activation without the need for any new impulse to be generated, so no need for a trigger. So it is different from the triggered activity, that here we don't need a trigger. As you can see here, for example, we have a part of the conduction system that branches into two pathways, and then they will merge again. One of the pathways has two properties. Pathway A has fast conduction but slow recovery time. Pathway B has slow conduction but fast recovery period. So let's assume that an action potential is coming down through this path, and then it will split into the fast conduction pathway and the slow conduction pathway. In the pathway A, or the fast conduction pathway, action potential will travel fast, and then it will be delivered down, for example, to the ventricle, and for example in this case, and also it will travel retrogradely through the slow conduction pathway. The action potentials, they will meet at one point, and they will cancel each other, because the autorhythmic fibers on both sides of the area of meeting are in the refractory period. So no action potential will be delivered or will be directed in either direction. Okay, so when the next impulse will come, what will happen? Here we have now for example, the fast pathway, the autorhythmic fibers in the fast pathway, they are still in the refractory period because they have slow recovery time. Now the impulse will travel through the slow conduction pathway because it has a fast recovery time, so now it is excitable, and will go down until here where the two pathways meet, and then it will pass down to the ventricle, for example, and also back through the fast conduction pathway because now it is recovered from the refractory period. So the impulse will go through pathway B to pathway A, and this will cause continuous movement of action potential, or the circus movement as the name shows. These arrhythmias that are generated by reentry are called reentrant arrhythmias, and they can happen anywhere in the heart, and they could be local, could happen in the atria or in the ventricles, or they can be global or generalized arrhythmias or reentry arrhythmias, like in the Wolff-Parkinson-White syndrome that we'll study in one of the slides in part 2 of the topic. Reentry arrhythmia is the most common arrhythmia mechanism seen in the clinical setting. So the most common cause of arrhythmias that we see in patients in the clinic is due to reentry or the circus movements. Here I will show you the atrioventricular node reentry tachycardia, which is one of the examples of arrhythmias or junctional arrhythmias, as we'll see later, as an example of reentry or circus movement. We have two types. We have the slow, fast atrioventricular node reentry tachycardia, which is the most common, 90 to 95% of the patients. And we have the fast, slow atrioventricular node reentry tachyarrhythmia or tachycardia. Here we have an impulse coming down. It will travel, as I explained in the previous slide, anterogradely through the slow pathway and retrogradely through the fast pathway. And this circus movement will keep moving around and around and stimulating both the atria and the ventricles at the same time. And this circus should be broken by defibrillation or by drugs. We have the other example where the action potential or the circus move first anterogradely through the fast pathway and retrogradely through the slow pathway. So it goes in the opposite direction. It is the least common cause or mechanism underlying atrioventricular node reentry tachycardia. As I said, it affects 5 to 10% of patients. Now, what are the different causes of arrhythmias? The causes of arrhythmias in general, whatever the site or location of arrhythmia in the heart. Arrhythmias can be caused by several causes. Number one, coronary artery diseases, ischemia and infarction, hypertension, cardiomyopathy, the different types of cardiomyopathies, valvular disorders. Any valve disorder can also lead to arrhythmia. Electrolyte imbalance in the blood, and potassium is one of the common examples. Injury from a heart attack or myocardial infarction. The healing process after heart surgery. Autonomic imbalance. Extreme sympathetic or extreme parasympathetic stimulation. Medications such as digitalis, beta-adrenergic blockers, calcium channel blockers, etc. Excessive consumption of alcohol, caffeine, nicotine, as well as anxiety, fatigue, fever, and infectious diseases. And finally, other medical conditions such as hyperthyroidism. So as you can see, we have a long list of arrhythmia, and if you have any patient with arrhythmia presenting to your clinic, you should find out the underlying cause, and as you can see here, we have a long list, as I said. What are the consequences of arrhythmia? A common question: is arrhythmia serious, or it is something that can pass without notice? Or does arrhythmia cause death? Is it a serious condition that lead to patient death or not? Some arrhythmias are so brief, so they come just in short attacks, or we call them paroxysmal. They appear, they last for a short time, and then the sinus rhythm will be restored. For example, a temporary pause or premature beat. That the overall heart rate or rhythm isn't greatly affected. So they are so brief and so short that where the overall heart rate and rhythm is unaffected. But other arrhythmias, especially if they last long, they might cause the heart to be too slow or too fast, or the rhythm too erratic or very chaotic, so the heart pumps less effectively. In such conditions, the cardiac output will decrease dramatically, and this will affect the blood supply of the vital organs like the brain and the heart. In arrhythmia, the heart doesn't beat properly, and this will cause reduction in the stroke volume and with subsequent reduction of the cardiac output, and reduction in the cardiac output will compromise the functions of the lung, brain, and all other organs of the body. How do we classify arrhythmias? Arrhythmias are classified according to two factors. One of them is the heart rate during arrhythmia, and the other one is the location, the site of origin of the arrhythmia. So the heart rate, bradycardias or bradyarrhythmias, where the heart rate is less than 60 beats per minute or less than 50 beats per minute at night during sleep. Tachycardias or tachyarrhythmias, where the heart rate is more than 100 beats per minute. High or slow heart rate or high or slow heart beats do not necessarily mean there is heart disease. Heart rate, for example, can increase during exercise, which is normal. Some extremely fit athletes have a resting heart rate less than 60 beats per minute. It could be as low as 50 or 40, and they are quite healthy and fit. The other factor that we use to classify arrhythmias is the site where they originate. We have arrhythmias that originate in the SA node, others in the atria or in the AV junctions or the ventricles, the right and or left ventricle. So we have, according to the site of origin, we have sinus node arrhythmias. We have atrial arrhythmias that originate in the atria, right or left or both. We have junctional arrhythmias that arise in the AV junction. Here we mean the AV node and the AV bundle. And ventricular arrhythmias, arrhythmias that originate in the right or left ventricles or both ventricles, the right and left ventricles. Arrhythmias, as I said, are classified according to the rate and the origin. So here we see a general overview of the arrhythmia classification. Here we have arrhythmias. If we see the ECG recording, we check the ECG recording and we see that the heart rate is less than 60 beats per minute. It is a bradyarrhythmia or bradycardia. It is either a simple sinus bradycardia or the heart block. The three different types of heart block that we'll study in part 2. On the other hand, if the heart rate is more than 100 beats per minute, then we have tachyarrhythmias or tachycardias. So after we come to know that we have tachycardias from the elevated heart rate, we check the QRS complex or QRS interval duration. If the duration is less than 0.12 seconds or less than 120 milliseconds, it is called narrow complex tachycardia, and the narrow complex tachycardia includes sinus tachycardia or the supraventricular tachycardias, including the atria and the junction, the AV junction. If the QRS complex or interval has prolonged duration more than 0.12 seconds or 120 milliseconds, we call this tachycardia broad complex tachycardia. Broad complex tachycardia means that the arrhythmia is arising from the ventricles, and this is either ventricular tachycardia or ventricular fibrillation, as we'll see in part 2 of the topic or of this topic. Supraventricular tachycardias originate or where the origin of tachycardia is above the ventricles. So originates in part of the heart above the or both ventricles. If a tachycardia has a narrow QRS complex, so it means the normal duration, it might be difficult to decide whether it is or the source of this arrhythmia is junctional or atrial. especially when the rate approaches 100 beats per minute, where the P waves become hidden in the previous T waves in the ECG. In this case, the P waves become indiscernible or cannot be used to determine whether the rhythm originated in the atria or the ventricle or the AV junction. So we don't know whether the arrhythmia is atrial or junctional. That's why we call it supraventricular. So we use the term supraventricular tachycardia when the P wave cannot be seen on the ECG. And if we cannot see the P wave, we cannot know whether this tachycardia is of atrial or junctional origin. That's why we use the term supraventricular, which covers both the atrial tachycardia and junctional tachycardia. Before we talk about the arrhythmias, we should know what is the normal sinus rhythm. What is a normal sinus rhythm? A normal sinus rhythm is a result of impulse that starts in the SA node and progresses to the ventricles through a normal conduction pathway, which means an action potential generated in the SA node traveled through the atrial fibers to the AV node, then the AV bundle or bundle of His, then the bundle branches, and then finally to the Purkinje fibers. Normal sinus rhythm is the standard against which all other rhythms are compared. So whenever we get an ECG, we compare that ECG with the normal sinus rhythm, and then we come to know whether we have a normal rhythm or we have an arrhythmia. What are the key features of a normal sinus rhythm, or what are the characteristics of a normal sinus rhythm? We have, first of all, we can notice that the atrial and the ventricular rhythm are regular. So we can see that the P waves and the QRS complexes are regular, and each QRS complex is preceded by P wave. So a P wave precedes each QRS complex, and each component of the ECG complex is present. So we can see the P wave, the QRS, and the T. The characteristics or the key features of a normal sinus rhythm: regular rhythm, it should be regular. It has a normal rate between 60 and 100 beats per minute, a P wave for every QRS complex, and all P waves are similar in size and shape. So when we check the QRS complexes, we can see that there is a P wave before each of the QRS complexes, and all the P waves are similar on the trace. All QRS complexes are similar in size and shape, and we mean size, especially the duration and amplitude. The normal PR and Q, another feature is a normal PR and QT intervals. And finally, we should have normal T waves. A normal T wave is a T wave that is upright and round. It should not be inverted. Okay, so these are the key characteristics of a normal sinus rhythm, and as I said, the rate should be between 60 and 100 beats per minute. We have some kinds or some types of arrhythmia. We have all the features are there except the rate is less than 60 or in other conditions more than 100, and there we'll have the sinus bradycardia and sinus tachycardia respectively. So what are the features or the characteristics of a normal sinus rhythm? Number one, the rhythm, atrial and ventricular rhythms are regular. The rate, atrial and ventricular rates fall between 60 and 100 beats per minute because the SA node's normal firing rate is 60 to 100, and all the impulses are conducted to the ventricles. Then the P waves are rounded, smooth, and upright in lead 2, signaling that is a sinus impulse has reached the atria. The PR interval is normal between 0.12 to 0.2 seconds and constant across the ECG trace, indicating that the impulse is following the normal conduction pathway. The QRS complex is of normal duration, which should be less than 0.12 seconds. representing normal ventricular impulse conduction. The T wave is upright in lead 2, confirming that there is normal repolarization that is taking place in the ventricles. And then we have a QT interval that is within the normal limit between 0.36 to 0.44 seconds. And finally, no ectopic or aberrant beats that appear on the ECG strip. I have said that arrhythmias can be classified according to the site of origin into sinus node arrhythmias, or just simply sinus arrhythmias, atrial arrhythmias, junctional arrhythmias, and ventricular arrhythmias. In this current session, I will talk about the sinus arrhythmia, and then in the second part, we'll talk about the remaining types of arrhythmias. In the sinus node arrhythmias, we have the sinus arrhythmia, which is an irregular arrhythmia, but the heart rate is within the normal range between 60 and 100 beats per minute. So we have just an abnormality in the rhythm, as we'll see in the respective slide. Then we have sinus bradycardia, where the rhythm is regular, but the heart rate is below normal, less than 60 beats per minute. Then we have the sinus tachycardia. The rhythm is regular, like the sinus rhythm, but the rate is higher than 100, within the range of 100 to 160 beats per minute. So it is up to 160 beats per minute. And we have one condition or two conditions. These are the sinus arrest as well as the sinus pause. Let's see what is sinus arrhythmia. Sinus arrhythmia, the heart's normal response to respiration, results from an inhibition of reflex vagal activity or tone. So the pacemaker cells of the SA node fire regularly. So it happens exactly that the parasympathetic tone on the heart, we know that the parasympathetic division of the autonomic nervous system decreases the heart rate. And during pulmonary ventilation or breathing, the parasympathetic tone will change. So during inspiration, the parasympathetic tone falls or decreases, and if there is a decrease in the parasympathetic tone, the heart rate will increase. While during expiration, as you can see here, we have during inspiration an increase in the heart rate due to a fall in the parasympathetic tone. While during expiration, the parasympathetic tone will increase, and this will lead to an increase or a decrease in the heart rate. So on expiration, the heart rate falls, and the heart rate in sinus arrhythmia stays within normal limits, but the rhythm is irregular and corresponds with the respiratory cycle, which means an increase in the heart rate during inspiration and a decrease during expiration. Typically, sinus arrhythmia results in predictable irregularities of the pulse. So if I check the ECG strip, I can predict the next irregularity that will occur in the ECG. Here we can see an ECG strip where there is a sinus arrhythmia. As you can see that we have less cardiac cycles during expiration and more during inspiration. So the rhythm is irregular. The heart rate is 60 beats per minute, which is within the normal range. The P waves are normal and they are similar in all preceding all the QRS complexes. The PR interval is within normal, 0.16 seconds. QRS complex within normal, less than 0.12 seconds. T waves are normal. The QT interval is also normal, within the normal range. And we have phasic slowing and quickening of the heart rate. This cyclic irregular rhythm varies with the respiratory cycle. So the rhythm Irregular heart rate is 60 to 100 beats per minute. Sinus arrhythmia is normal, particularly in children, young adults, and athletes. So it is a normal phenomenon that can be observed in children, young adults, and in athletes. Non-respiratory causes of sinus arrhythmia could be due to different conditions or diseases like inferior wall myocardial infarction, conditions affecting or involving increased intracranial pressure. With advanced age, we can see the sinus arrhythmia or the use of the drug digitalis. Sinus bradycardia and sinus tachycardia, all the characteristics of the sinus rhythm are there except the heart rate. Very slow, below 60 is a sinus bradycardia. More than 100 up to 160, it is sinus tachycardia, as I mentioned earlier. So you can notice here in this ECG strip that we have a very low heart rate. The rhythm is regular. Heart rate is 48 beats per minute. P waves are normal. The PR intervals are normal, 0.16 seconds. The QRS complexes are narrow, within the normal range, less than 0.12 seconds. And the T waves are normal. They come after the QRS. They are similar in shape. And we have a prolonged QT interval due to the low heart rate. And as I said, the main issue here is the heart rate less than 60 beats per minute. The rhythm is regular, heart rate is less than 60 beats per minute. Sinus bradycardia may occur normally during sleep due to decreased metabolic demands or in athletes. A well-conditioned heart can maintain a normal cardiac output with less than normal effort, as we'll see in the lecture about the cardiovascular adjustments in exercise. Other causes of sinus bradycardia include hyperkalemia, increased intracranial pressure, hypothyroidism, hypothermia, carotid sinus massage that will stimulate the vagal activity, vomiting, SA node diseases, cardiomyopathy, myocarditis, myocardial ischemia, myocardial infarction, and certain drugs like beta-adrenergic blockers, digitalis, and calcium channel blockers. This is all about the sinus bradycardia. In sinus tachycardia, the main issue here is heart rate above 100, between 100 and 120, and as you can see here, the rhythm is regular. The rate is 120 beats per minute. The P waves are normal and they precede the QRS complex. The PR interval is 0.16 seconds. The QRS complex is narrow and both values are within the normal. The T waves are normal and they follow the QRS complex. The QT interval is 0.34 seconds. And the main issue here is a heart rate above 100 beats per minute. As I said, rhythm is regular, heart rate between 100 to 160 beats per minute. It may be a normal response to exercise, pain, stress, or strong emotions, example fear and anxiety. It can also occur during heart failure, in cardiogenic shock, pericarditis, anemia, respiratory distress, pulmonary embolism, sepsis, hyperthyroidism, and taking drugs like atropine, aminophylline, epinephrine, alcohol, caffeine, nicotine, and amphetamines. Now let's talk about the sinus pause. From the name, it is a pause. The SA node won't generate an action potential or an expected action potential at the required time. So as you can see here, the rhythm is regular except for the pause. Suddenly an entire PQRST complex is missing. So an entire heartbeat is missing with its interval. It is a disorder of impulse formation in the SA node and is caused by lack of electrical activity in the atrium, also caused atrial stand still. So the atria are standing still without any electrical activity. During atrial standstill, the atria aren't stimulated and an entire PQRST complex or interval will be missing from the ECG strip, as we can see here in this strip. If we have 1 to 2 PQRST complexes missing, here we have 1, but even if we have 2, we call this sinus pause. If we have more than 2, which means 3 or more PQRST complexes that are missing, we call the condition sinus arrest. So in terms of concept, they are the same, but it depends on how many PQRST complexes that are missing. Then we have either sinus pause when 1 or 2 complexes are missing, or we have a sinus arrest when we have 3 or more complexes missing. Please notice that the sinus pause or the sinus arrest are different from type 2 second degree atrioventricular block, as we'll see in the second part or part 2 of this topic. In type 2 second degree AV block, we will see the P waves, and I will explain that in the respective slide in part 2. Okay, here we can see sinus arrest. We have missing 3 or more PQRST complexes, so we call this condition sinus arrest rather than a sinus pause. Causes of sinus arrest: SA node disease, carotid sinus massage, vomiting, chronic coronary artery disease, acute myocarditis, cardiomyopathy, and hypertensive heart disease, sick sinus syndrome, and drugs. In atrial arrhythmias, we have again different subtypes of atrial arrhythmias. We have premature atrial complexes, we call them PACs, and we have atrial tachycardias where the rhythm is regular but the heart rate is between 160 and 250 beats per minute. This 160 is the dividing line between sinus tachycardia and atrial tachycardia. We said sinus tachycardia is up to 160 beats per minute, but in atrial tachycardia it starts from 160 to 250 beats per minute. Then we have the atrial flutter. It could be regular or irregular, as we'll see in the respective example, and the heart rate here, or the atrial rate, is between 250 to 350 beats per minute. If we have an atrial rate above 350, then it is an atrial fibrillation, and it is irregular. It is entirely irregular type of arrhythmia. Let's start with the premature atrial complexes. Here you can see that we have premature complexes that originate outside the SA node and usually result from an irritable spot or focus in the atria that takes over as a pacemaker for 1 or more beats. So that ectopic in the atrial wall will generate 1 or 2 beats. So we can see here the rhythm is irregular when premature atrial complexes occur. So we can see here this irregular part, and here we have one premature. So we have the regular one, the premature one, a regular one, a premature one again, and then this will last for a few beats, and then we have again the regular rhythm, the regular sinus rhythm. The SA node fires an impulse, but then an irregular focus jumps in, firing its own impulse before the SA node can fire again. So this is SA node firing, there's an atrial ectopic is firing, and then SA node firing, ectopic firing, and this will last for a few beats, as I said, and then we restore the normal sinus rhythm. Premature atrial complexes may be conducted through the atrioventricular node and the rest of the heart, depending on their prematurity and the status of the AV node and the intraventricular conduction system. So whether they are in the refractory period, they are not in the refractory period, so it depends on the condition of the AV junction and the intraventricular conduction system, which means the bundle branches and the Purkinje fiber, and the refractory state of these parts. In atrial tachycardia, it is a tachycardia that is due to atrial activity. We can see that the rhythm is regular, but the rate or the heart rate is 210 beats per minute. So it is above 160 and below 250. As you can see here, the P waves are almost hidden in the T waves, in the previous T wave. The PR interval, if it is calculated, like here, they estimated that the PR interval is 0.12 seconds. The QRS complex is 0.1 second. The T waves are distorted by the P waves. The QT interval is short due to the tachycardia, and the heart rate is between 160 or 150 to 250 beats per minute. The pacemaker here is an atrial ectopic. So the SA node is no longer the natural or normal pacemaker of the heart. The atrial tachycardia is a supraventricular tachycardia, which means the impulse driving the rapid rhythm originate above the ventricles. The rapid heart rate shortens diastole, resulting in a loss of the atrial kick. That is very important for the last few millimeters of ventricular filling. This will reduce the cardiac output, lead to reduction in the coronary perfusion, and leads to ischemic myocardial changes. The atrial flutter is an atrial arrhythmia where the rhythm or the atrial rhythm is regular, ventricular rhythm is irregular. So we can see the flutter waves, they are regular, but the ventricular rhythm is irregular. The distance between two adjacent QRS complexes is different throughout the ECG strip. The atrial rate, if it is calculated, it is between 250 to 350 beats per minute, and in this example it is 280 beats per minute, so it is an atrial flutter. It is a supraventricular tachycardia originating in a single atrial focus. This rhythm results from Circus reentry and possibly increased automaticity. So the reentry can explain or could be an underlying mechanism for the atrial flutter. The P waves blend together in a saw-toothed appearance, like here, and are called flutter waves or the F waves, and they are a hallmark of atrial flutter. Whenever you see the P waves like this, you can immediately come to the diagnosis of atrial flutter. The AV node usually won't accept more than 180 impulses per minute, but the atrial rate is much higher, and this allows every second, third, or fourth impulse to be conducted to the ventricles. So the ratio of the atrial to the ventricular impulses will be 2 to 1, 3 to 1, or 4 to 1. So like here we have 3 to 1 and so on. Finally, we have the atrial fibrillation. The atrial fibrillation is an example of atrial tachycardia where the rhythm is irregular, and the rate is indiscernible, cannot be calculated because it is above 250 beats per minute. It is usually due to reentry circuits that arise in different locations in both atria. So the atrial and ventricular rhythms are irregular, and the atrial rate is more than 350 beats per minute. Atrial activity is no longer represented by P waves, but by erratic baseline waves called the fibrillatory waves. This rhythm may be either sustained, so it is continuous, or paroxysmal, just coming in burst or short attacks, and then the sinus rhythm is restored. The irregular conduction of impulses through the AV node produces a characteristic irregular irregular ventricular response, as we can see here, entirely irregular ventricular response. With this slide, we end our atrial tachycardia classification. In part 2, I'm going to explain the junctional tachycardias, the ventricular tachycardias, and the different types of the AV block. And also I'm going to talk about the principles of emergency as well as long-term treatment of arrhythmias. Thank you very much and wish you all the best.